Start with you. It's all you, Avery.
All righty. Hello, everyone. I hope everyone is doing good today. We want to welcome you to the first webinar of this kind, addressing the needs of LGBTQIA plus individuals with NMOSD and MOGAD. So we are really excited to have you here today. We have Dr. Conte, who we are so privileged to have, and we also have Nick, who won't be saying much but has prepped and prepared this whole webinar. So we're very thankful to both of them. Dr. Conti, I'll kind of let you do a little intro and then we can move on from there.
Oh, yeah. Hi, everybody. I'm William Conti. I'm a MS NMO MOGAD specialist outside Chicago in Indiana. Do a lot of research on this topic and hopefully you'll learn something. And ideally, I want this to be sort of more of a conversation, but I do have some slides that I'm going to share. I did my training at the University of Chicago for my fellowship, my residency at Loyola, and also medical school at Loyola in Chicago. And I've been in practice for about 5 years now. Maybe Avery, you can introduce yourself too.
Yes, pardon me. I'm not a great host. My name is Avery Allmond. I was diagnosed with MOGAD in 2017, and I am the proud L in the LGBTQIA plus community. My pronouns are she, her, and that is me.
Hi, everyone. My name is Nick. I am one of the TSF ambassadors for Florida. Also a transgender male, which means I was born female. Now I identify as male. I was actually misdiagnosed with MS last year, January 2023. And that diagnosis changed in this year in March to seronegative NMO. I'm happy to be here.
Thanks, guys. So just another shout out to Nick. This is his baby, and unfortunately, he's a little sick. Spent a lot of time preparing this for us, so shout out to you. So let me do the slides. Let's see. Here we go. Okay, so I've presented, this is like a copy and paste of my MS presentation, and I presented this at many conferences nationally at this point. And the problem with this deck, and I've edited it, is there's literally no research on this topic for NMOSD or MOGAD patients, literally nothing. I mean, in the MS world, there's like a couple of studies. I've read them all. There's like 5 of them, but none for NMO, not even like editorials. So I start off by talking about LGBTQ plus facts, because this is for a general audience. So the prevalence as of July 2020, 44.5% of the US population identify as LGBT, which is about 11 million people, which is a lot of people. For whatever reason, there's more females that identify as LGBT versus men. 42% of male identify, and then transgender people is about 0.58 of the US, 0.58% of the US population, which is over 1 million people. So I always tell people, like, even though you don't think you're going to encounter queer people, but we're around. And this is a really interesting slide, I think. So this is a Gallup poll done in February of 2023, which looked at Americans who self-identify as LGBTQ plus in 2022, and they broke it down percentage by generation, and this is as of 2022. At first glance, you'll notice that on the left is the silent generation, which is before 1948. It's going up over time. I don't think this is a representation that LGBTQ plus people are just, there's more gay people. It's more of the fact that there's more awareness and openness for the younger generation. So I think the true representation is looking at the millennial age. So the Q is included, which includes queer questioning. So the Gen Z generation, I think there's a lot of more awareness about like questioning sexuality and gender identity. So you're going to see a larger representation here. I think millennials have most people, I don't want to be too generalizing, there's less questioning and more, LGBT I think at this point in 2022. But it's really interesting that Gen X, baby boomers and silent generation, less than 5% in each generation as of 2022 are identifying as LGBTQ plus. And I think for these generations, there's still a lot of shame and internalized like homophobia that they're really it's kind of sad actually that there's not more out people in those generations to this day. It's actually quite shocking. But it's good. I think for the younger people of us, there's a lot more openness to it, and I think it's getting better, as the years go on. One thing I always want to mention, and really, hone in on is that there is a difference between gender and sexuality. So everybody has a gender identity, which is your inner sense of your own gender, and it may not match your sex assigned at birth. Whereas sexual orientation is related to the gender or genders of your romantic and sexual partner. And everybody, regardless if you identify as LGBTQ plus or not, has a gender identity and a sexual orientation, right? So, being transgender is not a sexual orientation. Okay, it's a gender identity. So, definitions of gender identity. So transgender is a person whose gender identity does not correspond to their sex assigned at birth, whereas a cisgender person is a person whose gender identity does correspond to their sex assigned at birth. And the gender expression is a way a person communicates their gender to those around them, such as their appearance or mannerisms. And one thing I like to show is the gender bear, is sort of the concept of gender and sexuality as a continuum. So what I love about, so one thing I love about using the plus in LGBTQ plus is that there's unlimited sexual orientations and gender identities. And I think that's really true when you think of it as a continuum. So this is the gender bear. There's different ways of expressing gender and sexuality. So there's outwardly expression, there's your internal identity, your actual sexual orientation, and your actual sex. So gender identity is how you feel and see yourself. It could be binary between a woman or a man, but it can also be on a continuum in the middle where some terms that we use is gender queer, sexual orientation. I think this is the most starkest thing. This really does exist on a continuum. Where who are you attracted to sexually and or emotionally? Is it a man, a woman, or somewhere in the middle? And what's nice about this concept is that someone can be, just barely, off of fully being attracted to a woman or a man, or it could be straight in the middle. I mean, it's really an amazing concept. Sex assigned at birth is less of a continuum. This is more of a biological concept. So really it's female, male, or intersex. And then gender expression is how you express yourself to others. Are you more feminine, more masculine, or somewhere in the middle? So I really like this concept. So then we switch gears and talk about health disparities. So part of my passion about talking about this topic is as it relates to MS, NMO, and MOGAD patients, really any kind of neurology patients, is that any kind of comorbidity with these diseases increases rates of disease activity, disability rates, and whatnot. So we always want to control for other health problems, and I think based on the research, there's a lot of health disparities that LGBTQ plus people face. So these are just some highlights. Overall, there's higher rates of disability, physical limitations, poor general health, cancer, and cardiovascular disease. This is just overall amongst LGBTQ plus people. So why is that? So I'm going to create a narrative here where we're going to lead to minority stress theory. So, as a minority group, there's a lot of discrimination against LGBTQ plus people. And this is as of 2019, this study looked at. So pretty recent. LGBTQ plus people overall face high rates of slurs. So it's like 57% of people who were polled, actually, there's a word used against them. Microaggressions. I actually thought it was interesting that microaggressions was lower than slurs. I actually think this maybe is a little bit underrepresented, maybe because I think some people get confused about microaggressions. So if you don't know what microaggressions are not like an outwardly sort of slur against you, sort of this like insidious, low level sort of awkwardness, I call it, that some people may experience. So, and what's interesting about microaggressions is that it could be, so some people who are uncomfortable around LGBTQ plus people, they will overly compensate for their uncomfortableness and try to be outwardly nice. So for example, I always use this, I think it was earlier this year, me and my husband went up to visit his grandparents in rural Wisconsin, which is normally fine, actually. But we went to like one of the country bars on the way in, and it was fine, but everybody was super, super nice and like way nice. And everybody's like, oh, we're happy that you're happy and this and that. I'm like, okay, well, would you be saying that to a straight person? Probably not. And so even though they're trying to make us comfortable, it was actually a microaggression because it then created a situation where I'm like, oh, well, I'm being reminded that I'm different than you and that you have to sort of, I have to feel bad. I have to feel bad because you're trying to create a nice environment for me. And I don't need that. I can just act normal. So that's actually a microaggression. That's actually, I think is really common that a lot of people face. Other microaggressions could be just like, someone walks in a room that may be like, especially like a genderqueer person who's more, not binary, presenting themselves, and people like stop talking and look like that's a microaggression. Sort of the voyeurism of asking many questions about somebody. You don't want to be voyeuristic about asking questions about how we should talk to you or not. And so that's interesting. I actually think microaggressions is a very confusing topic. So I actually think it should be a little higher, but but they found it was more than 50%. More than 50% was sexual harassment. So a lot of LGBTQ plus people actually are harassed a lot, and even up to the point of violence. So these are pretty high numbers still. Not only that, but there's a lot of healthcare discrimination that happens. Thankfully, these numbers are less than 50%, but they're still perpetuated. This is in 2019 as well, a different study. So this survey found that 18% of LGBTQ plus people actually avoided healthcare due to anticipated discrimination. So it's this concept of, not wanting to go into a healthcare setting because you're worried about being discriminated against. And that could be, this whole voyeuristic thing I'm talking about earlier, where, there's all these extra questions that get asked to us that probably wouldn't be asked to a, straight person. So a lot of people get anxious about it, especially trans people. Now, a little bit less, but pretty similar rate actually experienced healthcare discrimination. Okay, so 16% of people in 2019 are still being discriminated against in the healthcare setting, which is crazy. Now, transgender patients across the board were higher for both of these. So 23% avoided or delayed care due to anticipated discrimination. And interestingly enough, it was a higher number than it was for the anticipated discrimination that actually had a negative experience. So versus overall the whole LGBTQ plus community, there's less that actually experience discrimination, but more avoided it. It flips for trans people. So I always tell the story about this trans neurologist I know. She was telling me that she ended up having to be brought to the hospital by ambulance eventually because of a severe asthma attack. She, was still going through hormone replacement therapy, and she didn't really want to go to the hospital for this asthma exacerbation because she just didn't want to explain her hormones that she was on to the doctors. And it eventually led to her having to go to the hospital by ambulance. And now I think there's a component to doctors are usually the worst patients in general. So I think there's a little component of that happening with her. But it's an interesting idea that even a doctor on the flip side was worried about other healthcare professionals discriminating against her. And so I think that's it was eye-opening to me when I heard that story. So this leads to minority stress theory. So LGBTQ plus people are a minority group, and there's been hundreds of studies that have shown evidence that LGBTQ plus discrimination leads to adverse health outcomes. This is the idea that there's this low-lying discrimination or anticipatory discrimination that happens that then creates stress in the body, which then leads to physical symptoms and diseases. This could be either due to interpersonal discrimination, like bullying, and it could also be structural discrimination, like laws or policies. What's interesting about this concept is that it's linked to health harms, even for those who are not directly exposed. So even like hearing about violence against another LGBTQ plus person in the news would create minority stress for me, for example. And this isn't like a conscious thing that happens, it's internalized. So it creates internalized stigma, low self-esteem, expectations of rejection, and fear of discrimination. This is really at the subconscious level, usually. Intersecting identities like gender, race, and different socioeconomic status may exacerbate harms. But protective factors like social support theory, so peer, community, and family support actually protects against minority stress. Access to affirming healthcare and social services and inclusive practices, this all protects against this. So part of my advocacy for this presentation and lecturing is to create inclusive healthcare environments and to tell other healthcare professionals ideas for them to create inclusive practices because, as doctors, we have an opportunity to, protect against these things, even though as a neurologist, I'm not directly involved in, for example, trans healthcare, where I'm not prescribing hormone replacement therapy, but I have the opportunity to create an inclusive environment for that individual who, for MS and especially NMO, it's a lifelong disease where, it's going to be a long-term relationship. So creating that inclusive environment really protects against these things. And that's really all I got, just because there's not much data to show. It's more general. But I've been seeing some chats come through, so let me just review. Is there any questions? Maybe Avery or Nick, any thoughts, reactions?
I thought that slide with the gender bear, I think that was such a good visual of really understanding the differences between, all of those things that we were talking about. So I think that was such a good visual that we can probably put on the Facebook or something, because I know that would definitely help someone understand that a bit more.
I have a question. And I agree, the gender bear was awesome to be able to see it so clearly outlined, I think would be helpful for anyone, even if you are a part of the LGBTQIA plus community. It's good for us to all be on the same page with jargon. But Dr. Conte, I have a question for you. I mean, so clearly there's a lot of work that needs to be done and a lot of data that needs to be collected, and even if it's experiential data. And you're a member of TSF's Coalition for Health Equity, which really aims to support underserved communities. So from your perspective as a doctor and a researcher in this space and an advocate, what can we be doing as ambassadors and of course the foundation to further this kind of understanding in our community?
Yeah, I think there's sort of two aspects to that question that I could answer. Is one from an advocacy standpoint and one from a research sort of patient-directed standpoint. So I'll start with my perspective on what I think us as a medical community should be doing. So we should really be researching these topics in regards to health outcomes for neuroimmunology patients. And there's been a lot of push for looking at different health outcomes for Black and brown patients, different racial minority groups, which I think is great. But I think when you go a step further and look at some of these smaller minority communities, especially looking at socioeconomic class, I think that's an interesting one to look at as well. And I'm really interested in the intersecting identities. So a Black trans woman who's poor, right? Like that's many different minority groups sort of intersected into one. And how is that interaction different than, like for me, I'm a gay white man. It's a bit different. Um, and so I'm really interested in that kind of concept. I think what we need to do is sort of look at health outcomes. So, for example, with the MS world, is there actually a different disease course that these people have? And it may be no, maybe it's similar. But maybe we'll find that, for example, they're getting lower efficacy disease modifying therapies, for example. And I'm curious to see what treatments they're doing. I think from an advocacy standpoint, it also is creating awareness for controlling other comorbidities. So comorbidities is like other health issues, because as I just mentioned, with minority stress, there could be other health issues that pop up. So we want to catch those before they become a problem and really affect the disease state. The other thing is that I had just thought of was support services. So in the MS world, research has shown that LGBT Q plus people, once they're diagnosed with MS, they withdraw from the queer community because they have this chronic disease. And on the flip side, they also feel less comfortable to join usual MS support groups. So there's been groups in the MS world that have been great, like LGBTQ plus MS groups, right? So it gives it flips both things around. So they get their LGBTQ plus support and also their MS support. So that's like a good example of that. I think Nick has some resources as a whole that have been created. And unfortunately, a lot of these are online, which is great, but I think a lot of them needs to be in person. It's just hard to do, I think.
Well, I think it's also
That was great insight.
yeah. Oh, sorry, go ahead.
No, no worries. I just kind of wanted to touch on that intersecting identities portion again. How do you think those intersecting identities influence the experiences of LGBTQIA plus individuals that are in clinical trials that have NMOSD and MOG?
Yeah, and so in the MS world, it's interesting. I keep going back to MS, even though this is about NMO and MOGAD. So one thing I think is disturbing are, and I don't want to like be too generalizing here, is that the HIV patients, for example. So I think to my knowledge, every single clinical trial for MS therapy has excluded HIV positive patients, just HIV positive. Now, obviously, HIV is not unique to the LGBTQ plus community. However, it's higher rates amongst us. And but they totally exclude patients who are HIV positive, even though they might be undetectable with normal lymphocytes, normal CD4s, they're still excluded. And what happens is then the label for the drug will then say a contraindication for going on this drug is being HIV positive. Okay, well, what about the HIV positive MS patient, right? What drug do they go on? Because technically, really, almost all the drugs have a contraindication for them. And it's like, well, then what's left for them are these lower efficacy therapies. And they might then, you know, not have as good as a disease course. And so I've talked to a lot of the pharma companies about like we need to increase inclusivity. None of the trials collect the SOGI data. So SOGI data is sexual orientation and gender identity is what it stands for. None of the trials collect that. So and I do trials for these companies, all that they have in the portal is male, female. That's it. There's no sexual orientation or gender identity. So we just need to start like collecting that information just so we are aware of what the different outcomes are.
That is crazy that that's not collected, actually.
Yeah, it's just male, female in the portals.
Wow. Michael, take note of that.
Nick has a comment or a
Yeah,
question.
Nick.
Yeah, thanks, Dr. Conte. I wanted to know, what would you recommend for any providers that are listening that may have LGBTQIA plus patients? What would you recommend for them to create a more inclusive environment so their patients are able to talk openly with them and feel more comfortable?
Yeah, so I'm gonna answer this as a doctor and a patient. So as a doctor, I think what we can do is just create a nice, safe, open environment. And there's many ways to do that. It doesn't have to be too crazy. One of the simplest thing is to collect the SOGI information. So research, so it's actually interesting in my MS presentation. I didn't have this slide here. But research has shown that HCPs, healthcare professionals, like 70% of them don't think that patients don't want to disclose their sexual orientation or gender identity. But when they looked at the patient level, only 10% didn't want to share that information. So like a vast majority, 90%, actually wanted to disclose their sexual orientation and gender identity. So there's this mismatch between us and the patients, and we sort of need to bridge that gap. One ways, and also research has shown that patients prefer to disclose through nonverbal means. So they like to put it on like the intake form. And I agree with that as a patient. I don't want to create this big like to do about, oh, I'm gay, I'm married to a man. Like, I just want it to be like normal with like what, a straight person would do. So a lot of the EMRs actually you can electronic medical records, that is, they have it's actually in Epic, which is the most common one, I think, the biggest one. If you go into my chart, you can actually on your phone, not even in an encounter, you can change your name to a like, the name that you want to be called. So my legal name is William Conte, but everybody calls me Billy. So my chart actually says Billy Conte on it. It's just like, okay, but someone who's transitioning or going through gender affirmation can change their name that way. Because there's this whole thing with the insurance company still. And then also it has sex assigned at birth, it has gender identity, and it's left open-ended, has sexual orientation, has all that in my chart. So, I encourage patients to go through that. I think as a patient myself, what I like to see in a doctor's office, it's nice to see a pride flag up somewhere. It could be a small one. I just think it's nice, it's like, oh, they get it. It's not, um, because I'm always searching. I don't know about you, Nick or Avery. Like as a queer person, I'm always looking around for a threat, and it's nice to sort of like just you see a flag, you're like, oh, okay, this is cool, like this is fine. And it just sort of it just de-escalates things. And I live in Illinois, so like things are pretty good around here outside Chicago, but still it's nice to see sometimes. There's older doctors I always get a little nervous about. um but we're always searching. So that's my advice.
There's a
Yeah,
burning
thank
question
you.
in the chat.
So someone in the chat asked, how about for gay people who got transverse myelitis during an attack of NMO or MOGAD? The end effect, they still have problems like erectile dysfunction. It is not easy to share this topic to a neuro doctor. What can we do to express this neuro or any recommendation having this problem or treatments? Thank you.
So I'm going to answer the same way I did as both a patient and a doctor. So I always tell, so first of all, if your neuro's asking you these questions, they're not doing their job, first of all. Especially with transverse myelitis, sexual dysfunction is very common. And they should be asking about like urinary function and sexual dysfunction, but it can be really awkward. And especially amongst queer people, like actually, I'm pretty sure research has shown this, that actually, no, it was trans people that are the most uncomfortable sharing sexual health information. They looked at that in the MS world. So what I do is that I actually think this is a great opportunity for like the doctor patient relationship of. So what I do for patients usually is I do, like, first of all, if they're trans, I do an organ inventory. just sort of check over all the organs and actually just figure out what organs they have. And then I talk about the 7 Ps. That's like an easy thing to remember for doctors if anybody's listening. So that the 7 Ps are preferences, partners, practices and pleasure, protection, planning, and partner violence. So it's a great opportunity to sort of assess safety and things like that. But it so this all sounds is fine and dandy. As a patient, I don't really mind being asked about sexual health. I I think some doctors get uncomfortable about it with queer people because it's especially if they're like a straight cisgendered person, they're like they might not know, but like it could be brief and it could be detailed. It just sort of is a nice opportunity. And fortunately with transfer smileitis, the question is what you do about it. And that's, it's often multidisciplinary. It could be very hard too. Okay, Nick, you had a thought.
Yeah, sorry. No, I just want to share my experience here a little bit with that because as a transgender person that is on, hormones, originally born female, but now identify as male, and as someone that also experienced sexual dysfunction along with this, and being on hormones, testosterone changes your anatomy. And when I tried to explain to my neuro about the problems I was having, um, and she redirected me to something else that was more female based. But what I was trying to explain to her is I was having a problem with the erectile tissues, and I don't think she was getting it. So that was like the what's the word I'm searching for here? Like the disconnect between the patient and the doctor, understanding one another. Because in that moment, she just wasn't educated enough on what a trans man's body may go through being on hormone therapy. So that creates an even more difficult hurdle to balance and to get over. Um, so I can totally relate to what the chat was saying, but also just putting out there's another hurdle that even trans patients may have to navigate and go through as well.
Yeah, I think this is why I always tell, when I'm presenting this to doctors about the organ inventory is really important because I didn't really talk about gender affirmation in this presentation, but what's beautiful about gender affirmation is that it's highly individualized to the individual. And one trans person, their gender affirmation may look very different from another person. And so the organ inventory is actually really important because then it's like when you're counseling patients, you don't have to be, you could be like, okay, well, this is what you focus on, not this. And it's actually a simple thing to do. And I think probably Nick, you'll agree, like, I don't think people like trans people are like, I think it's a normal thing to be asked about. But
Yeah, absolutely.
I admit it could be awkward sometimes, but it could be even more awkward if you don't get past it.
Avery, you're on mute.
Thank you. Kind of going along that in a different perspective, I think as being a lesbian woman of childbearing age, I think that conversation has come up a lot more recently with my doctors. And just kind of seeing how some providers are very willing and accepting and wanting to offer resources, because we do have to go about, having children a little bit differently. And then you have those providers who don't. So I just want to let it be known that if you do feel like that you don't want to disclose something to a certain provider, I think that's completely okay. Like you said, Dr. Conte, everybody's experience is different. So I think it's important that we recognize that, but we also need to recognize that there is some bias that can come up in these certain conversations.
Yeah, the bias is interesting. So I'm like a big I was about to say believer, which is not true because it's not something to believe. It's a fact about implicit biases. So during my master's program, for my public health master's, I was taking this interesting class. I don't even know what the class was about, but the professor, she did a lot of research in racial inequities, and so she had us all do. I think it's through Harvard. You can do it online for free. This implicit bias test, I guess. And there's different ones. There's like I mean, the race one is the main one, but there's like stuff about socioeconomic class. There's stuff about gender. It's really interesting. It's actually, I wish all HCPs, healthcare professionals, would go through it themselves because implicit bias, it's not something that's like you can really control. It's just something to be aware about. And that's how you control it. It's like you can't change your implicit bias, but you just create awareness so you can think about your behavior surrounding it. And obviously explicit bias, that's alarming and that shouldn't exist in healthcare. But I think implicit biases are a very interesting concept.
And do you think that provider bias is something that could potentially lead to delays in help and diagnosis for NMOSD and MOGAD patients or even inadequate care?
Well, I do know that what's been well researched is looking at women's experience in neurology. That a lot of biases against women. That women are hysterical. That women experience or have less pain, and this and that. Like all these stupid myths that I think women um, have it really tough in healthcare where I mean this is well researched. This is not just me saying it. It's just that there's a lot of medical gaslighting that happens to especially women. I don't know the data behind other minority groups, but I would expect it to be the same with all minority groups really. um which is why I think the intersection of identities is really interesting to look at. um in the multiple minority groups, how do they access the healthcare system for this disease that can really be sneaky sometimes? That's not the typical presentation where like, half of the body's not moving. It's a sneaky disease sometimes, MS, NMO, and MOGAD that you hear these patients that it's like years and years and years of symptoms before they finally get an MRI. I mean, you hear that all the time.
And kind of going along with that, with the provider bias and even things like denial of services or hostile environments, what advice would you give a MOGAD patient or an NMOSD patient that sees a provider and they feel like there's some type of provider bias or implicit and non-implicit bias?
Yeah, I think I'll answer this as both a patient and a doctor again. So I think as a doctor, I would, if I'm doing something, if my implicit biases are acting up and I'm not aware of them acting up, I really hope a patient doesn't like necessarily confront me, but like brings just raise awareness that, oh, I think a block's happening here. I would love for a patient to do that for me. Now, as a patient, I think that's really difficult to do. To depending on the person, right? If it's usually what we're talking about here is not the neurologist that you've been seeing for years and years and years with this disease that you have a rapport with. That's usually not the issue. The issue is your first access to into the system with a new symptom before you're diagnosed is the issue. And so you're meeting these people you've never met before. So it's very tricky to bring something up. I think approaching it with compassion would be helpful. So I think if a patient, like, as a, this is coming back as a doctor, if a patient confronted me like very like in my face about it, like I would get blocked probably, and that would just sort of like create conflict. I think if someone like approach me with compassion, where like, I'm feeling this about that, and can we like start over and think about this a different way? Like I'd probably be like, maybe there'd be a little resistance at first, but like I'd be like, okay, fine, let me check myself and go. But I mean, that's also me. Um, I can't speak for everybody else, but I think a gentle approach is usually best, a little sugar on top. And I think most doctors or healthcare professionals would probably be okay with that. Um, I mean, in a more extreme example, there's many different options usually depending on where you're located with other, doctors and stuff. You can always seek other doctors, but that obviously ends up delaying care. Um, the other thing is, I also think what happens sometimes is that sometimes patients get labeled as a difficult patient, right? That's like the medical gaslighting that I was talking about before. And again, approaching it with compassion, I think, is good. You don't want to like come guns a-blazing against the HCPs, and because we're just gonna get blocked then. I don't know what your experience was of this, but I'm just trying to think of the best perspective. The problem is the access issue is if you're in like a rural area where there's just one neurologist for in the states, one or two in the region, that gets difficult when you don't have other options. Okay, I think Nick had a comment.
Yeah, it's interesting you mentioned that because I'm in a very rural area in Florida, and it can be very conservative here and very closed-minded, and especially the access to healthcare being in this rural area is very difficult at times, and even you know going through just getting out the hospital. Um, where my local hospital, very small hospital, doesn't have a in-house neurology team, and so everything gets consulted out. Um, so and I'm having I'm just and Avery, I'd love to know your opinion if you've ever had any type of disparities and discrimination in healthcare, but trying to reach my neurologist and having the staff like respond in a timely manner when I'm going through these different difficulties with accessing, the right care at a local hospital, and finding out from a patient that goes to the same doctor that they have no problem accessing,
Mm,
the care, that they have no problem. Like they call them right back, they answer right back on the portal, and it's hard not to think there's some type of bias going on there. Um, and it's not even between me and the doctor. I think it's more so the staff than the doctor, which creates even more difficult environment at times because they are my direct connection to that provider, which is being limited. So it's like multi levels that sometimes a patient has to go through just to reach adequate care and like a timely matter. And it can be, stressful for the patient, especially when they're going through any type of exacerbation state of their disease. And I think living with these chronic illnesses on top of like the different, mental health that comes with being in the LGBTQI plus community. Um, and then having discrimination on top of that, it's just like a multi-level effect that keeps going. Um, that's it can become extremely difficult, I think, to manage as a patient. So yeah, I just want to touch bases on that, and Dr. Conte, if you have any responses, and Avery, if you have any stories of yourself about it, I'd love to know.
Yeah, I'm really glad you brought up the mental health aspect of it. From experience, I know that just being a woman in general, there's already bias that are usually coming from male providers against us, as it is. But then, like you said, you're adding those layers of, well, I'm a black lesbian female, so you have all of those stereotypes automatically placed on you, even if it's, implicit or non-implicit. But going along with the mental health aspect of it, Do you, Dr. Conte, or even Nick, do you guys have any recommendations as far as what people can do if they are a part of the community and they are struggling with not only their identity, but they're also struggling with their diagnosis? What are some things that these people can do to make sure that they're taking care of their mental health?
So before I answer that, I just want to comment about Nick's story. I think the access issue is a really tough like situation. Like I was thinking about like when you're talking about like my setup in my clinic, it's so hard to like manage the patients that aren't in front of you. And I just want to be clear, I'm not making any excuses for your doctor. I'm just sort of saying, I'm like thinking, "Ugh, I wonder if any of my patients have like felt that about me." And I'm like, it's just so hard because like I want to be like 100% undivided to my patients, but I'm right face to face with them, like nothing else in the world bothering me. And I get so upset if I get like a phone call from the hospital in the middle of the conversation. Thankfully, I don't get much of those. But like, the my chart messages, the phone calls to the nurse, it's like my nurse is working with me all day too with patient facing. It's so hard. I think there's a big problem about, I mean, there's a huge shortage of like doctors in general, especially neurologists. And it's just like we are swamped. And it's just like I don't know the answer to this because like we want to keep people out of the hospital. But we also do that by you know just really giving them undivided attention to the patient at hand. And it's just like, I just don't know what, that's why I have a life outside of work. And it's just so tough. I think you kind of, I don't know what the saying is, you kind of hit the bull by the horn, I guess, that about, you're not even sure if the messages are getting to the doctor, right? Because there is a filter, and that's the way at my clinic too, because most of the my chart messages can be dealt with by the nurse usually. It's usually like, oh, I need to transfer my refill to this pharmacy, right? So it's so tricky. And I don't know the solution to that. Now Avery's question to me. Um, well, first I would make sure you're safe. We want to make sure there's a safety plan in place, first of all. If there's not, you basically need to go get help. Do not stop, go and collect $200. Go seek help immediately. Um, I think the support groups are really actually like the undervalued player here, is that it doesn't have to be like a formal support group. It's the social support. You want to create a village around you, and unfortunately, not everybody has that. Um, but it's so important to create some sort of like-minded individuals who know what you're going through. Um, you can sort of commiserate about having issues reaching their doctor, and you know things like that you can commiserate about. And I also think it's important to have like good hobbies. I'm like passionate about hobbies. I think having a passion project for yourself, you don't have to think about your worries all the time, is really important, not as a distraction but just sort of an enrichment to your life. Obviously, with mental health issues, there are medicines involved, but I don't even think medicine is the answer most of the time. It's one, actually it's really interesting, medicines like antidepressants for depression. So the research has showed that antidepressants only help about like 30% of the depression symptoms. The rest is like through psychotherapy. So everybody wants like a quick med to fix them, but it just doesn't exist. You have to go through you have to do the extra work. And but support groups are great, I think. And just the social support theory. I think a lot of LGBTQ plus people, there's also, so I was about to mention, familial support, but a lot of LGBTQ plus people, there's a lot of family issues surrounding their identity. And I don't, I mean, I think if you have that familial support, kudos, but you need to think about your own village, and maybe that's family, but it might not be either.
And Nick, did you have anything to add to that?
Like I definitely agree with what Dr. Conte said, and I just wanted to mention to everyone that TSF does have a LGBTQIA plus support group on Facebook um, that we just started, that we're trying to get ramped up now. And just providing a safe space for everyone to connect that, is a part of the community. But yeah, Dr. Conte, I totally agree with what you said, especially it's hard to navigate the healthcare system. Being a nurse for so long and, now being the patient on the outside, I see how busy people can get and, navigating the messages and going through everything. It becomes, it's like, how do we create a solution when we don't have enough people, essentially? So yeah, I definitely get that. But yeah,
Yeah, I don't know the solution. I wish I
yeah,
did.
me too.
And I wish it was that simple that we could just say, here's the magic fix for that. But
Mhm.
unfortunately, there's a lot of learning that still needs to be done, I think, on all ends.
Yeah.
So thank you both for that input on that. It looks like we have time for about one more question. I also want to open the floor up to anybody that has a question for any of us up here. I'm always happy to answer it off to the side too if you don't feel comfortable sharing in the chat. Um, but I kind of just wanted to touch on one last thing. For transgender individuals undergoing gender affirming care, how do treatments for NMOSD or MOGAD intersect with hormone therapies or other transition related healthcare?
Well, from my perspective, I'll start by answering. I think from a medical standpoint, I don't think there's any contraindication for going through gender affirmation um, and going on disease modifying therapy. On the contrary, it probably only help some of the symptoms that people are experiencing by going through hormone therapy or gender affirmation. So I say go ahead. You'll need to interrupt the treatment.
This was incredible.
And Nick, do you have anything from a personal, sorry, Sumaira.
No, no problem.
I just wanted to see if
Um,
Nick, if you had anything to add from a personal standpoint.
yeah, sure. That was actually one of my first questions when I got diagnosed. Like, will this impact, my hormone treatment? And so it was difficult. And I remember researching, and it was only like one study I found on PubMed that, it wasn't that much to go off of, but not a lot of doctors could really answer that for me. And just, knowing other trans people with MS, specifically, one of their doctors told them that it would actually be harmful to them. So there can be a lot of misinformation. There could also be like a lack of information, a lack of research for contributing to that. And, and maybe some biases in there as well when you come down to it. So, but yeah, for me, I am still on my hormone treatment, and I don't think it's impacting my disease at all. My doctors seem to agree, so that's the route I'm taking personally.
Yeah, I think it needs to be individualized, but I I would say go ahead. Okay, Michael has a question.
Michael has a question.
Hi, everyone. Don't think I can turn on my video, can I?
You should be able to. Hold on.
I'm not
Oh,
seeing.
hold on. Here we go.
Okay.
Oh, Michael, we're so excited you're here.
Uh,
Where is he?
Michael, you muted yourself.
Right here.
There we go.
Coming on. Can you hear
Hey,
me?
Michael.
Yeah,
Hi,
Hi,
everyone.
Michael. Everybody say hi, Michael.
Hey, Michael.
Sorry I was late. My fault. First of all, thank you, Dr. Conte, Avery, Nick, for leading this session. I know it's not, it's an important topic. It's not always the easiest topic to address. I have a comment and then I have a question for you all. So the comment is, as you know, like we've been living through some crazy times the past 8 years, but with Black Lives Matter and other movements, I think a lot of folks that feel like they're allies to the LGBTQIA plus community, well-meaning, but perhaps a little bit naive or clueless, or just not with the flow of things. When issues about DE&I and race, et cetera, started coming up, a a lot of folks like me, so, I'm an older white guy. Sumaira likes to tell everyone I'm ancient, but I don't think I'm that old, but I'm older. Okay. I'll accept that. But, the first observation I had was when these topics came up, the older white guys would just like be quiet, like, oh, I can't say anything. I'm going to lean back. This is not my time. I might get in trouble. I don't know if I'm going to say something wrong. I don't want to offend anyone. But what I learned was that actually that's not enough. Like, actually, you can't just sit back and just, passively listen. So the question I have for all of you is, you all have your own experiences, but each of you, what could folks like me do to be more supportive? Like, what do we have to do to kind of improve the situation for the LGBTQIA plus community in any way, but, specifically around healthcare? So I'll just open it up with that.
I think just kind of my simple answer is educate yourself. I think, there's so many different components to being a part of the community with the labels and the pronouns, which is something that people don't really understand. But small things like that can definitely affect people in the community. And I always say you can't know what you don't know. So it's important to educate yourself on what it is that we deal with on a day-to-day basis, as well as some obstacles that we go through, because I think sometimes there's no really one answer to how one can help. But I think the biggest thing you can do is be a support and just kind of being a listening ear as well.
Great. Thank you.
All right, Nick.
Yeah, and I definitely agree with what Avery said, and just also having those key individuals that you're allying for, um, asking them if it's okay to ask them a question, because like for me personally, I don't get offended by welcome questions because that's my opportunity to actually educate that person, and so they're more aware, and I'd rather them ask than not ask, you know. But and that's why I say ask them first because some people may not be as open as I am, but I think that's an important aspect to it. And navigating this and also just holding just give yourself grace during this is a new learning curve for you. um as someone else may pick up something new, like I don't know, a new hobby, a guitar or something, you have to give yourself grace there's a learning period of everything, so I think that's important as well. As long as you know where your heart is and you're trying your best, you can only do as much as you know you can only do your best in things, right? So I think that's important as well. But yeah, just if you ever have questions that you can definitely ask me. I won't be offended.
Thank you.
Yeah, I
Yeah.
think just being curious is really important about this, the curiosity. So I think we all kind of say this similar thing. Um, it's just that's my thought.
And, I just noticed, we work with someone who was involved in the setup of Rainbow Health. I don't know if you knew this company. It was set up to serve the healthcare needs of the LGBTQIA plus community. They sadly just announced that they had to shut down. They just financing wasn't working out. But it does raise this question. We have this in our Coalition for Health Equity discussions too, like, is there a way for us to do something creative to support this community through telehealth, for rare neuroimmune conditions, not just limited to NMOSD and MOGAD, that's too small a community, but maybe extending it to AE and even frankly, MS, MG, CIDP, all the other conditions. I don't know, Dr. Conte, if you've had any experience with that model, or if you think that could help folks, particularly if they're in rural communities
Yeah,
or very isolated, maybe too conservative communities, et cetera.
yeah, it gets tricky because it's like there's licensing issues and payer issues with that, but it just gets so tricky. I think a bigger bang for a buck is, the education of other HCPs, is to sort of spread the word, I guess. Because I would hate for like a neuroimmunology patient to have to like leave their region to like seek help because they're not getting equitable care. But I mean, yeah, I mean, it definitely happens.
Well, I just want to say, Michael, I think it's very telling of who you are as a person to come on this platform and to ask this, especially with your generation and being that older white male, as I always, tease you about. But I think it's really nice to see you so curious about how to approach this with grace and respect.
Thank you. I'm not that old. I just want everyone to know. I'm not
Why is it saying so old?
Old enough.
Michael can hang later and longer than
Well, I
everyone
think
else I know.
oh, yeah, probably. Well, thank you guys. I think we are about to wrap up here, but I just want to thank you, Nick, and Dr. Conte for being a part of this discussion, and also everybody watching from the live stream. If you have any questions at all that you don't feel like publicly sharing, I know, as Nick was saying, we're pretty open for the most part, and no question is going to offend us personally. So if you want to shoot us a question, we'll be more than happy to respond back to you. We also have a really great list of resources for the community as well. I know it can be really hard to navigate all of the challenges that come with it. So one of the support group that we have for the LGBTQIA plus community, Nick, I'll let you kind of tell the days and times about that, but that's a great resource to utilize as well.
Yeah, so right now we're just getting started, so it's just a Facebook group. It's not a virtual group just yet. But you can join on Facebook. It's open right now. And if we get enough people there wanting a virtual group, then of course I'm open to doing that as well.
Absolutely. Well, thank you guys all for coming again. We really appreciate it. We really appreciate you being a part of this discussion. And just know that you are loved and you have a support system here. If you don't have one close to you, we're always going to be here for you as a TSF fam. So thank you, everybody, again for joining.
Hi.
Thanks, everyone.
Thank you, everyone. Bye.